Good morning to one and all. Respected senior doctors, colleagues, I welcome you all to this gastroenterology clinical meeting. I'll present few interesting cases. First case is a case of cholestatic jaundice. A 27-year-old male presented with jaundice and generalized itching since 2 months. There is no abdominal pain, no fever, no abdominal distension, no weight loss. There is no history of hematemesis or melena. There is no history of any recent drug intake or any native medicine intake. And only important history is just 3 months prior to this episode, patient underwent cholecystectomy for calculus cholecystitis. No diabetes, hypertension, no any major comorbid conditions. On examination, patient was conscious, oriented, afebrile, and deep ectric. There is no edema, lymphadenopathy. Vitals were normal, and respiratory rate and SpO2 was normal. On systemic examination, per abdomen was normal, soft, no organomegaly, no ascites, and other systems were within normal limits. So these are the investigations done. CBC was normal, and bilirubin was elevated. Predominantly, it is a direct bilirubin of 21.9, and indirect is very small fraction, and total protein is 6, and albumin is 2.7. There is no AZ reversal, and elevated alkaline phosphatase, normal being within 98, and minimally elevated ALT AST. Then urea creatinine was normal, and viral markers were normal. So working diagnosis post cholecystectomy with obstructive jaundice. So probably a biliary stricture. This was clinical diagnosis. Patient had intensive itching and jaundice and history of cholecystectomy. This is what our initial clinical diagnosis. But we did ultrasound abdomen that showed normal except absent gallbladder, no biliary radical dilatation, and CVD was normal. So we are not still satisfied with maybe ultrasound. Maybe still is clinical suspicion of post cholecystectomy with obstructive jaundice. Want to roll out biliary stricture. So we did MRCP. MRCP also normal. There is no biliary obstruction. So patient initially treated with UDCA and vitamin K and the supporting measures. Patient continues to have persistent jaundice and itching. So what next? So whether this patient is having autoimmune hepatitis with phlegmatic sclerosing cholangitis or autoimmune hepatitis with primary biliary cirrhosis. Because autoimmune hepatitis usually does not have any itching. The patient's jaundice with itching means cholestasis. Cholestasis will not be there in pure autoimmune hepatitis. Either it is overlap of primary sclerosing cholangitis or primary biliary cirrhosis. So these are autoimmune markers, ANA, SMA, LKM, protein lipophoresis, even Wilson's workup, everything is normal. Then what to do? Actually, there was a liver biopsy one that showed mild to moderate portal and periportal inflammation, eosinophilia, moderate focal marked bile ductal proliferation, and moderate cholestasis and mild bile ductal damage. These are the histopathological slide. It's showing inflammation. Then these are special stain that showed marked uptake of this cholestasis. So what is the diagnosis? This is a benign condition. On important history, actually, this initially it was denied by the patient. Actually, he was recently married, wife was with him, and mother says that history of similar episode 5 years back, same jaundice and itching. It was recurrent condition, so benign recurrence was there. So diagnosis is a brick. What we call is benign recurrent intrahepatic cholestasis. It is a very extremely rare condition. It is a genetic disorder. It is autosomal recessive. Occurs in 1 lakh or 1 in million patients. So very rarely we come across these kind of cases. It is a benign recurrent intrahepatic cholestasis. This patient requires only supportive care. Some of the drug rifampicin especially works for these cases to reduce the itching and jaundice. Patient after starting rifampicin, he was already actually bilirubin initially 24. Currently it is 2. He is doing well. And this condition may recur in future also. So after this, I'll show some few interesting videos. This 75-year-old male presented with obstructive jaundice. MRCP showed large 2 cm mid CVD calculi with narrowed CVD, narrowed lower CVD. So when you have large calculi with narrow lower CVD, very difficult for ERCP. ERCP meant mainly it's a stone of 0.5 centimeter to 1 up to 1.5 centimeter easily you can retrieve, and we can do lithotripsy also. When lower CVD is narrowed, very difficult to retrieve large calculi. So other option is open or laparoscopic CVD exploration. Another thing is spyglass cholangioscopy. These are the recent advances in gastroenterology, especially interventions. Actually, it is a baby scope, like one mini endoscope goes into the through the ERCP channel and directly entering into the bile duct. We can see the large stone in the mid CVD. Actually, this is the whole meal laser. We are using the lower meal laser to break the large stone into a smaller one. It is thanks to the urology department to providing this volume laser machine. The excellent one. Otherwise, patient has to be subjected for either laparoscopic or open civilian exploration and collocoid and other thing. With the advent of this whole wheel laser and laser lithotripsy, you can avoid major surgery. These large stones can be easily fragmented and small fragments can be easily retrieved using balloon or small baskets. These are laser. Sorry. The spyglass cholangioscopy is a direct visualization of the bile duct, just like mini endoscope going into the biliary ducts, and we can use for both diagnostic and therapeutic cases. Diagnosis means if we have any hilar stricture or malignancy is suspected, we can take biopsy from the hilum. Another interesting case is a 55-year-old male admitted with severe acute pancreatitis, and he was treated initially conservatively with medical management. 4 weeks later, patient developed large walled off necrosis with necrotic debris. So one option is large walled off necrosis with some necrotic debris. We can go for ultrasound guided pigtail drainage. And it is a necrotic component is very minimal. When lot of fluid is there, then we can go for USG guided pigtail drainage. Or if the necrotic component is more, then other option is open or laparoscopic necrosectomy. Other option is endoscopic drainage. When actually endoscopic drainage should be attempted when there is a necrotic component is less than 30%. When 70% should be fluid, then only should be attempted. So this showed more of fluid with some necrotic component. Actually large pseudocyst was there. This is a USG guided needle. Actually this is the stent. One side was deployed, that is in the pseudocyst. Actually you can see very minimal necrotic debris. These are all fluid components. This is the endoscopy view. This is the endosonal view. The stent, one part is inside the pseudocyst, another part in the stomach. You can see that more of it is a fluid, infected fluid only coming. So once this complete fluid component has come out, then we did repeat endoscopy. That showed still a lot of necrotic material in the thing. What we did is we initially dilated the cystogastrostomach site using the balloon. While dilating, that stent was actually in this space. We removed the stent. Then we did dilatation of the tract. This is the cystogastrostomach site. Actually, we were using controlled radial expansion balloon to dilate the tract. This is the stomach. This is the cystogastrostomach site. Actually, previously metal stent was there. We removed, and once after dilatation, we are entered into the pseudocyst cavity. This is the cystogastrostomach site. Actually, you can see a lot of necrotic material was there. Using rat tooth and snare, actually we completely cleared all the necrotic material. Actually, it took 2 sessions. First 1 hour, after 3 days, after 4-5 days, repeat another session. Then final one small minimal things were there. In between, we used this hydrogen peroxide to irrigate actually this is the pseudocyst cavity. You can see almost cleared except small necrotic debris were there. That was cleared in another session. Normally, this kind of case, I should go for surgical open necrosectomy or laparoscopically. Even open laparoscopic necrosectomy also sometimes may require 2 times or 3 times. Initially, we thought it is a fluid component is more and necrotic debris were minimal. Then we attempted lumen opposing metal stent. Then after that, lot of necrotic material was there. We did endoscopy necrosectomy in 2 sessions. Almost everything is cleared and patient is doing well. This is another case. Actually, last time I presented the similar case. So, this is an endoscopic ultrasound guided gastrojejunostomy. So, this is actually a follow-up case. This is a 78-year-old female present with abdominal pain, bloating, and vomiting of stale food, and contrast enhanced CT abdomen showed duodenal growth with obstruction. Actually, this is the endoscopy. Actually, third part duodenum is actually is a duodenal growth completely obstructing the lumen. This endoscopy ultrasound guided we did actually gastrojejunostomy. Actually showed this video last time. Actually this is a follow-up case. Actually this is a jejunum, and actually using US guided needle we punctured the jejunum, and one part of the stent was actually we deploying into the jejunum. Actually to distend the jejunum, actually we injected some colored fluid. Actually this is a stent. Actually the fluid is what we inject into the jejunum is coming into the stomach. This was done 3 months back. So I will show what happened after 3 months. This patient came out regular follow-up every month. Actually after 3 months we did repeat endoscopy that showed the metallic stent with what we deployed 3 months back in situ. Actually everything is well expanded. You can see the jejunum through endoscopically. Directly difficult to enter into the jejunum. What we do is we did CRE balloon dilatation of the stent. Okay, this is one probably afferent loop, another this side is probably efferent loop. When we try to enter directly into the jejunum, sometimes the stent may get displaced. So what we have to do is we have to direct the tract. Actually the jejunum, we enter it into the jejunum. This is probably efferent loop. Another loop probably this side is there. We can enter other loop also. Sometimes it can displace the stent. That's why actually we dilatation and enter the jejunum and complete. Actually after 3 months there is no signs of any gastric stasis. Abdomen is completely clean. There is no outlet obstruction. It works as good as a open or laparoscopic gastrojejunostomy. Thank you.
What have you done with the lesion?
So lesion, she is a 78-year female, already metastatic, almost stage 3, inoperable case. This is adenocarcinoma, does not respond to chemoradiotherapy. This is a palliative. Instead of palliative GJ, we did US guided GJ.
Thank you, sir. Just in case any questions? The spy colonoscopy.
Yes, sir.
Why it's called spy?
I don't know. There is spying inside the bile duct.
And what is the size of that baby scope that you
That is a 10 French catheter, sir.
10 French could go?
Yeah, 10 French catheter. Normally we place a 10 French stent into the CVD. Same size it is. They designed that has got even up, down, right, left movement, even working channel, one small this one port to pass a whole wire laser. This guide wire. Sorry, this laser probe also. Same urology what we have. Same thing. Only we need to have long 5-meter that laser probes.
You passed that laser via working channel of the spyglass.
Spyglass or working glass. That has got even one port for irrigation, one port for guide wire. You can take biopsy also. Even recently they invented basket also. In a small magneted stent, it cannot be retrieved. Normal ERCP, we can go into the bile duct. Under vision, we can retrieve the stents using spy guided basket.
You should have put an image of that scope.
Scope. Next time I will do it, sir.
I have to see his procedures. What saw you doing spyglass procedures. What is the dose of rifampicin use?
Same 450 milligram. That is actually an enzyme inducer that brings down the cholestasis.
Okay. Non-tuberculous indication.
Yes, sir.
Any more questions?
Thank you.
So this is my first case. He is a 45-year-old male patient having a right upper quadrant pain, jaundice, fever with chills of 3 days duration. He had some tenderness in the right hypochondrial region. He was suspected to have acute cholecystitis, and laboratory parameters revealed WBC count was elevated and LFT was suggestive of obstructive pattern, and ultrasound abdomen followed by higher imaging done. So this is the MRI abdomen showing a multi-loculated cyst in the right lobe of the liver with some daughter cyst inside, and there is some rupture of the daughter cyst into the biliary tree. You can see some daughter cyst in the distal CBD causing the obstructive jaundice and some cholangitis. So the next plan is going for ERCP and drain the biliary system. After selective CBD cannulation, biliary sphincterotomy done with a bow sphincterotome, and you can see some dark bile is draining. The next step is doing a balloon trawling and extraction and clearance of the bile duct. So the stone extraction balloon is introduced into the CBD, and you can see some daughter cyst extracted from the biliary tree. 2 or 3 times the balloon trawling is done and the CBD is cleared. Then a biliary stent is plastic stent, 10 French into 10 centimeters straight plastic stent is deployed into the CBD. So this is the simple plastic stent. Post procedure cholangitis got improved and surgical gastro opinion obtained. Dr. Jaipal have seen this patient, and the plan was treating this patient with albendazole 400 milligram twice daily for next 3 weeks, and patient discharged home, and he got readmitted after 3 weeks. Laparoscopic procedure was taken after 3 weeks during the second admission. The cyst, I'm not a surgeon, but I got the information from the Dr. Jaipal, and initially the de-roofing of the cyst was done, and all the hydratin membranes and cyst they sucked out. This is the clear cyst cavity, and they placed a part of the omentum inside the cyst cavity, that is omentopexy, and all the precautions were taken, and they instilled hypertonic saline into the cystic cavity, and all the precautions have been taken to prevent the rupture of the cyst and the spreading into the peritoneum. That is one of the complications can happen during the surgery. And this is the removed gallbladder with some stones. So patient again prescribed with some albendazole, and he got discharged home. And after 2 or 3 months, the CBD stent was removed, and the patient is doing well, and there is no recurrence. He is under follow-up for the last 1 year. Moving to the case 2, he is a 83-year-old male. Currently, he is in our hospital, and he had comorbidities like Parkinsonism, polyradiculopathy, systemic hypertension, and CKD, admitted under Dr. Asokan sir. Patient had a tachypnea, and he had a severe abdominal pain, and initially he was suspected to have a bowel perforation, and CECT abdomen was taken, and he also had a tachypnea for which CT thorax was taken. It showed acute pulmonary thromboembolism, and the Doppler study of the lower limbs revealed deep vein thrombosis in the common femoral artery, and he was started on low molecular weight heparin. And clinically, he had a severe tenderness all over the abdomen, and there was gouging also. And laboratory parameters showed obstructive jaundice, and CCT abdomen revealed that there is a lower CBD calculus. He had cholangitis and biliary pancreatitis also. Amylase lipase were elevated. He had a sepsis, and he was on noradrenaline support, and higher antibiotic meropenem was started. He was under high flow O2. He was managed in MICU. The plan is emergency ERCP under high risk. All the risk versus benefits were explained clearly to the family members, and they agreed. And the patient intubated in MICU and shifted to Scopy OT. So this is the ERCP procedure, and the CBD cannulation done with routine bow sphincterotome, and the guide wire is selectively placed into the common deep bile duct deeply. The next step is doing adequate sphincterotomy to expel the stone, and this is the cholangiogram picture showing a filling defect in the lower CBD. Sphincterotomy was done, and the stone extraction balloon is introduced into the CBD, and you can see the nice yellow colored stone. This is the stone which causing the obstructive jaundice and biliary pancreatitis. Biliary pancreatitis happens because of the pressure effect by the stone. It causes compression over the pancreatic duct, and people tend to develop biliary pancreatitis. They present with severe pain and the typical features of pancreatitis. And 10 French into 10 centimeter. This is the Sogendra Tannenbaum stent from Cook Medical. It was placed into the CBD. Post-procedure pancreatitis and cholangitis improved. Rails to feet started gradually, and noradrenaline tapered, and tachypnea is settling. And patient weaned off and shifted to IMCU, subsequently to room. And two sites from blood culture from two sides showed E. coli growth, and it is sensitive to meropenem. It is continued. Currently, patient is stable and doing well. Moving to the case number 3, he is a 87-year-old male patient. He had a systemic hypertension and COPD, and he presented with a biliary colic, and ultrasound showed acute calculus cholecystitis, and there was a large stone in the lower CBD. It was around 1.5 centimeter. So the options for these patients, those days CBD exploration was done, where longitudinally the CBD is open and they extract the stone by surgical method. Once the ERCP evolved, there are various gadgets we can use to extract the stone, like Dormia basket, which can be connected with the Alliance gun. You can crush the stone, do the lithotripsy, and you have got a spyglass cholangioscope. Sir already explained a case, the laser lithotripsy. So this is the spyglass cholangioscope. It is attached with the routine ERCP scope, and you can you have the small wheel and big wheel of the spyglass scope to manipulate the scope. So you can do the laser lithotripsy. This is the spy bite. You can take the biopsy when you suspect some malignancy of the CBD, when there is some indeterminate strictures, when you cannot classify whether it is a benign or malignant. You can do the spy bite using spyglass cholangioscopy. So these are the options left in this patient. But in this patient, we cannot prolong this procedure because already the age is 87. He had COPD problem. So there was a concern from the consultant anesthesiologist. So this is the simple method to extract the large stone, particularly from 1 centimeter to 1.5 centimeter. We can use the biliary sphincteroplasty method. So the idea is, after selective CBD cannulation, you do a sphincterotomy as a routine by using bow sphincterotome. After that, a controlled radial expulsion balloon, this is the CRE balloon, is introduced into the CBD and kept over the biliary sphincter choledochus, and this CRE balloon is attached with the Alliance gun, and they apply the pressure and it expands and it dilates the sphincter adequately. And after you have to keep for 2 minutes. Once the sphincter is adequately dilated, you can use the stone extraction balloon and you can extract the stone. This is the large stone extracted from the CBD, and stent was placed. Post procedure, patient had a CO2 retention and a delayed extubation was suggested from the anesthesiologist. So he was shifted to MICU. Patient had pulmonary edema, tachypnea. The troponin T level was 247 and pro-BNP more than 35,000. Bedside echo showed a E of about 35%. Initially, opinion obtained from Dr. Arun Gangadhar and Vikram Vignesh as a routine fitness measures, and they reviewed the patient, and diuretics, heparin, antiplatelet, statins were started, and patient extubated after 24 hours in IMCU, and BiPAP and nasal prongs O2 was kept and shifted to room. So patient about to get discharged. The surgical gastro opinion obtained from Dr. Prakash. He suggested interval cholecystectomy after 6 weeks. But the Monday was the discharge plan. On Sunday morning around 8 a.m., the staff nurse called me from a ward, and she told the patient is having bradycardia. The heart rate is about 40 per minute. I informed Dr. Vikram Vignesh. He rushed, and ECG was taken. It showed a 2:1 AV block, and immediately patient was shifted to CCU and a temporary pacemaker was placed, and patient was stabilized in CCU and then shifted back to room, and permanent pacemaker implantation was done in the same admission under CM scheme and discharged home safely. The patient came for review once, and we insisted subsequent interval cholecystectomy and followed by stent removal, but though it was insisted very clearly, patient lost follow-up. This is case 4. He is about a 65-year-old male patient. He had a locally advanced CA head of pancreas. It was inoperable tumor, and he had obstructive jaundice because of the tumor infiltration into the lower CBD. And initially ERCP was done elsewhere. Plastic stent was placed, and he had features of cholangitis and stent block, for which he got admitted here, and the plastic stent was removed, ERCP was taken, plastic stent was removed, uncovered biliary SEMS was deployed as a palliative measure to drain the biliary system. The cholangitis got settled, and he had a persistent back pain and upper pain, for which opiates were prescribed regularly, morphine and fentanyl patch at the appropriate dosage, but still he was complaining of severe pain. So there was no significant improvement in terms of pain. So how to improve the quality of measures? Quality of life. So there are two options. You can go for a percutaneous intervention, celiac plexus block, or US guided celiac plexus block. Where if you use a US guided celiac plexus block, you have got a real-time visualization of the celiac trunk. You can directly inject the neurolysis material into the celiac plexus. So opted for US guided celiac plexus block. So this is the US guided celiac plexus neurolysis video. Once you put the US scope at the level of G junction, you can directly visualize the aorta, and you can see the celiac artery takeoff, below which there is SMA takeoff also there. And anterior to the celiac artery, you have the celiac plexus. If you carefully observe, there is a hypoechoic area, that is the celiac ganglion. Using a 19 gauge FNA needle, you puncture from the gastric cavity and go up to the celiac trunk. It is about 1 centimeter gap, but you should not inadvertently enter into the aorta or into the celiac artery. That will lead into complications. So what is the material used for neurolysis? It is 0.25% bupivacaine and absolute alcohol mixture. We can inject about 10 ml to 20 ml. There are two methods. You can directly inject into the celiac plexus, into the plexus, that is the central method, or you can inject on both sides, that is bilateral methods. We have to prepare the patients before the procedure, because patient can develop transient hypotension since we block the plexus. So adequately we need to hydrate the patient, 500 ml to 1000 ml saline bolus given just prior to the procedure. And any serious complications can happen. In the literature it is report 0.2% inadvertently when it is injected into the aorta or into the celiac artery. It can cause other complications or any abscess formation or retroperitoneal bleeding, but it is only 0.2%. We can use in patients with CA pancreas with severe pain, or in patients with the chronic pancreatitis also we can use to reduce the pain. What is the percentage of pain relief? In CA pancreas it is about 70 to 80%. In chronic pancreatitis it is about 50%. But in chronic pancreatitis we should not use neurolysis. We have to use only block, that is bupivacaine followed by triamcinolone injection. We should not use absolute alcohol as a neurolytic method. This is case number 5, almost a similar case to already saw presented a WPN case. He is a 35-year-old male patient, primary school teacher. He had a history of chronic alcohol consumption. He developed acute necrotizing pancreatitis. It was severe necrotizing pancreatitis. He got admitted at his native place in Dharmaburi. He got admitted twice and conservatively managed there. And after discharge, for 2 months, he had a significant upper abdominal pain, for which he came to our hospital, and ultrasound was taken. It showed a large walled of pancreatic necrosis with a matured wall in the body of the pancreas. And higher imaging was also taken, CCT abdomen and MRCP. It confirmed the WPN, and there was some disruption of the pancreatic duct. He had a mild ascites also, and as a complication of chronic acute necrotizing pancreatitis, he had a splenic vein thrombosis. And so whether to go for a medical intervention, medical gastroenterology intervention like endoscopic necrosectomy, or open or laparoscopic necrosectomy. We had a discussion with Dr. Jaipal, and endoscopic intervention as a necrosectomy procedure, now it is followed worldwide as a first line treatment in patients with either a pseudocyst or a WPN, symptomatic pseudocyst or symptomatic WPN, or size more than 6 centimeter, causing some obstructive symptoms in the form of obstructive jaundice or gastric outlet obstruction features, or patients presenting with significant pain. We need to drain the cyst endoscopically. So this patient was planned for a cystogastrostomy, and hot axio stent, that is the lumen opposing metal stent, placing a lumen opposing metal stent, hot axios was the plan. This is from Boston Scientific. You have the, this is the instrument, hot axios instrument. This is the stent part. The tip has got an electrocautery method. This is the only one instrument. Directly you can puncture using a US. So this is the stent. After placing the stent will expand like this. So this is the video of US guided cystogastrostomy. This is the large walled of pancreatic necrosis. This is the matured wall, and the hot axios is punctured from the gastric cavity. Before puncturing, we should make sure in the needle trajectory area there should not be any vascularity, and we use a Doppler signal to make sure there is no vascularity. This is the hot axio. Stent is punctured into the WPN, and the stent is delivered. So this is the one end of the stent. After placing the stent, this patient was planned for a chemical necrosectomy or a combined method. You can use the endoscopic necrosectomy also. So nasobiliary drain. So this is the one end of the stent from the gastric cavity. It's a lumen opposing metal stent. It opposes the both lumens from the gastric cavity, from the cystic cavity. So this is the ERCP cannula is introduced into the cystic cavity, and guide wire is placed, and the ERCP cannula is removed. After which a nasobiliary drain threaded over the guide wire, and it is placed into the cystic cavity. And the plan is instilling diluted hydrogen peroxide about 100 ml twice daily or thrice daily. There is no strict guidelines how much can be injected, and the duration also. So in our institute, before this case, sir did one case, and we instilled hydrogen peroxide for 1 week, about 100 ml twice daily. So the nasobiliary drain is placed into the cystic cavity, after which we need to place a Rayleigh tube, because all the fluid will come into the stomach. The patient might get aspiration, so we need to place a Rayleigh tube, and there should be continuous drain to drain all the fluid for the next 24 hours. We will keep the patient under NPO and support with IV fluids for the next 24 hours. So once everything is ensured, there is no other issues, we will start the oral liquids, and simultaneously we inject hydrogen peroxide also for next 1 week. The ward sister is trained, so how to instill the dilution and the method, how to use the how to instill from the outside. It is fixed over the nostril. So the patient underwent a relook endoscopy after 1 week, after adequately using a diluted hydrogen peroxide. Hydrogen peroxide acts as a bactericidal, and also it sloughs out all the necrotic material. This is the large necrotic material you are seeing inside the cystic cavity. So the endoscope is passed into the cystic cavity. This is the nasobiliary drain. The color got changed. A lot of necrotic material inside the cavity. So we can use various gadgets like rat tooth forceps, or we can use the Dormia basket, stone extraction basket, or a Roth net where we use to retrieve some foreign bodies, or polyps after polypectomy. We retrieve the polyps using a Roth net. So there is no specified instruments meant for necrosectomy. It's in the evolving. So we use already existing gadgets like forceps or basket, snare, like that. So by using multi-bite biopsy forceps, some material have been removed, and again using URCP cannula, some hydrogen peroxide is instilled at various places inside the cavity. And patient discharged home after 1 or 2 days after this procedure. He allowed to take a normal diet, and the stomach acid also it goes into the cavity, and it also acts as a it also helps to remove the necrotic material. So the patient again came for review after in between also he came for review, and serially ultrasound was taken to ensure the size is reducing, and this is the relook OGD after 8 weeks. So most of the necrotic material came out, and only some slough were there. So this was the some slough inside, and that was also removed by using some instrument. And after that the stent was removed, and before removing the stent, did ultrasound. It showed a reduction in the WOPN when compared to the first initial stage, and patient relieved from pain, and there was no other complications. That's all. I want to thank Dr. Murugesh sir and surgical gastroenterology doctors team and the hospital management. So endoscopic intervention success comes from the teamwork. I want to thank all the consultant anesthesiologists, radiologists, and our endoscopy technicians, staffs, and everyone. Thank you so much.
Thank you, sir, for the interesting cases. Questions, please.
What is the cost of that metallic stent?
Sir, it's about 1 to 1.5 lakhs. Sir.
Lakhs.
Yes, sir. It was Dr. Kenneth Binmoller. He was the from USA. He invented this lumen opposing metal stent. We can use the plastic stent. We can use the normal self-expanding metal stent. But when we use the plastic stent, it won't drain. But whereas in simple pseudocyst, we place only the plastic stents. So it's only a clear fluid. So normal self-expanding metal stent is cost is less, but the chance of migration is more. So after the procedure, that's why this lumen opposing metal stent is invented. Nowadays it is followed everywhere, sir, all over the world. And endoscopic intervention is the first line management to drain the cyst.
The celiac axis block
Yes, sir.
under ultrasound.
Yes, sir.
You did it yourself or the interventional radiologist?
No, sir. Interventional radiologist. We call for help, and Dr. Arun Ramaraj sir is always coming for US procedures. And for this celiac plexus block, we only did, sir.
Okay, so regarding the first case is the hydatitis.
Yes, sir.
So the biopsy has proven hydatitis.
Yes, yes.
So X-ray, chest X-ray is normal.
Yes, it was normal.
You do routinely hydatitis serology in this patient.
No, we did not do, sir.
When you extract
Since it was confirmatory by the imaging and the methods.
the large stones, when you remove like 1.2 centimeters, you remove endoscopically or leave it as
Which ones?
the large CBD stones.
We don't remove the stone. It will be expelled. Yeah, it will be expelled by its own. We don't remove the stones.
There is no
gallstone ileus.
There is no risk of theoretical risk of obstruction of the
Gallstone ileus. Yes. But generally, the size is more than about 2 centimeter like that. There might be a chance of ileus, but we generally don't remove the stones up to 1.5 centimeter. But the stone size is more than 1.5 centimeter. Either we should go for surgical exploration or laser lithotripsy to compress the to crush the stone actually.